me really in giving them proper engagement and think I have found a lot of patients who are having undue tachycardia or sympathetic dysfunction, and some of my patients are even arrested. So I have stopped using cardiac stimulator in my practice. I don't use it.
One more question, sir. Is there any, as you said, SM,
Yes.
is,
Sorry. Yes.
is there any role of SIM in winning a post?
I very clearly showed I don't use at all neither ventilation.
But listen my question. In a post-operative patient like cardiac surgery.
Not for anymore. If we don't use SIMP for anything. Either the patient can breathe, either the patient can't breathe. I very clearly say that. If a patient needs ventilator, let him ventilate full, either give profen. And one more thing, if a patient can breathe spontaneously, giving pressure support at 20 is as good as putting them on controlled ventilation. That will be better. And one more strategy to early beginning is let your patient breathe spontaneously as much as possible. You will be able to give them early.
In many forward hospital, maybe.
Sorry?
In many forward hospital, this is using
that's why I have specially said it is harmful. Up to you. Thank you. No question. Now next session. Sorry.
The question is when to do and not to do. To resolve this dilemma, I would like to invite Dr. Atul Mehta, who is chair at Department of Pulmonary and Critical Care Medicine, Sheikh Khalifa Medical City, Abu Dhabi. Over to Dr. Atul Mehta.
My name is Atul Mehta, and I'm very thankful to Dr. Rajesh Mishra and Dr. Atul Parikh for inviting me to this prestigious meeting. The agenda of my talk this morning is related to how you perform flexible bronchoscopy in the intensive care unit. I heard some talks this morning, and I understand there are lots of cardiologists in this group. There are lots of anesthesiologists in this group, so I would like to know, to make myself comfortable, how many of you call yourself pulmonologists? Please raise your hand. Very few. So maybe I'm a black sheep in the crowd, I guess. How many of you call yourself bronchoscopists? Please raise your hand. Just a couple. Maybe Rajesh Bhai, I should go back home.
Yeah, that's why I called you. That's why I called you. You have to include both.
So how many of you don't call yourself bronchoscopists but still do bronchoscopy? Please raise your hand. Well, I knew that some of you would be doing that. So in the next 20 minutes or so, and Rajesh will pull me off the podium if I extend my time limit. But what I'm going to tell you, how one should do bronchoscopy in the bronch suite. By interest, by training, I am a bronchoscopist, and that's the reason I stand in front of you on this podium. Can we advance this slide, please? It is not moving forward. Is there some magic here? I have to... All right. Very simply, when would you like to do bronchoscopy in the intensive care unit? And of course, most of the time you do this thing when you see lung infiltrates, especially when you suspect ventilator-associated pneumonia or healthcare-associated pneumonia. Airway trauma requires hospitalization to intensive care unit, inhalation injury, bronchopleural fistula, if patient is in the intensive care unit for the foreign body aspiration, if you are performing lung transplantation and patient develops acute rejection, and if you want to confirm the position of the endotracheal tube or double lumen endotracheal tube, you would do flexible bronchoscopy. Also, there are several therapeutic indications to do bronchoscopy in intensive care unit, such as difficult intubation, especially with the conventional tube or even with double lumen tube, placement of the combi tube, percutaneous dilatational tracheostomy requires bronchoscopic guidance in most instances, heavy hemoptysis, which is going to be my next talk, foreign body removal, management of bronchopleural fistula, especially at the stent or the valve placement, central airway obstruction, airway secretions, and atelectasis. Now, before I move forward, let me just show it to you, tell you what happens when you do bronchoscopy in an intensive care unit patient who is being ventilated. Whenever you do bronchoscopy on a critically ill patient, the first thing you will notice that mean arterial pressure would be increased, followed by increase in the stroke volume, pulmonary artery pressure. There are increased chances of tachyarrhythmias, bundle branch blocks, and if you are measuring intracranial pressure, bronchoscopy would increase intracranial pressure as well. However, as there is increase in the mean arterial pressure that compensates for cranial perfusion pressure, and hence there is no significant difference in the cranial or cerebral perfusion during bronchoscopy. Also, flexible bronchoscopy produces hypoxemia for a variety of reasons, and it reduces myocardial perfusion. Why does one get hypoxia during bronchoscopy? There are several reasons for that. Flexible bronchoscope is a foreign body in the endobronchial tree. Any foreign body in the endobronchial tree will produce bronchospasm. Bronchospasm leads to VQ mismatching, and hence there is hypoxemia. Sedation leads to hypoventilation, and so does upper airway obstruction from the bronchoscope itself, which produces hypoventilation and thus hypoxemia. Unnecessary use of suction causes reduction in the FiO2 and hypoxemia, and if you cause bleeding or instill large amount of saline into the lung, that will produce shunt and hypoxemia. And because of these changes, hemodynamic changes and hypoxemia, flexible bronchoscopy is contraindicated in intensive care unit patients if there is no consent, if there is lack of patient cooperation, if there is incorrectable hypoxemia despite use of peak above 10, there is uncontrollable electrolyte imbalance or arrhythmias, there is hemodynamic instability, coagulopathies, or if you are an inexperienced operator. That is the reason I asked you that you are not a bronchoscopist, yet do bronchoscopy. If there is improper facility and if there is an auto peak of more than 15, you do not, I repeat, you do not want to do bronchoscopies on those patients. Okay, relative contraindications, as I mentioned, increased intracranial pressure, impending respiratory failure, laryngeal edema, uremia, pulmonary hypertension, which is causing hypoxemia, pregnancy and intensive care unit, impending myocardial ischemia or ongoing myocardial ischemia, and lung abscess in an intensive care unit situation. What a bronchoscopy suite must have before you pick up the bronchoscope in the intensive care unit. Every bronchoscopy suite must have ice-cold saline, methylene blue, flumazenil, naloxone. Every bronchoscopy suite must have Fogarty catheter size 4 to 7, and also 200 centimeter long balloon tamponade catheter, which is nothing other than a long Fogarty catheter, nasopharyngeal tube, foreign body remote, accessories, transbronchial needle aspiration, endobronchial electrosurgery, bite block, chest tube, and cryotherapy unit is optional. Okay, so how do I do flexible bronchoscopy in an ICU patient? I decrease the FiO2 to 100% and reduce the peak below 5. I may even do ambu bag ventilation to coordinate biopsy, which I may do on ventilated patients. You require either T or Y connector, and I'll show you the pictures of that. If you perform transbronchial or bronchoscopic lung biopsy, that is usually performed without fluoroscopy. Transbronchial needle aspiration is safe in MICU setting. Recent myocardial infarction is not an absolute contraindication. You measure the risks and benefit ratio. Propofol. Let me repeat, propofol is an excellent drug of choice for sedation in intensive care unit if you want to perform flexible bronchoscopy. There is no need to use anticholinergics such as atropine or glycopyrrolate before the bronchoscopy anymore. SBE prophylaxis in selected patients. In selected patients, all bronchoscopy does not require SBE prophylaxis. ICU patients under the circumstances of prior history of endocarditis, prosthetic valve, hemophilia, malnutrition, immunosuppression, and insulin-dependent diabetes mellitus, I would consider SB prophylaxis. How do you manage hypoxemia in intensive care unit during flexible bronchoscopy? What is the goal? all throughout the bronchoscopy procedure, SpO2 must remain above 90%. If it drops below 90%, I will remove my bronchoscope. Continuous oximetry in all patients, oxygen via nasal cannula in all patients is given, or through the endotracheal tube in ICU setting. Avoid unnecessary suction, that is the most common mistake carried out or performed by the bronchoscopist. Okay, because patient is not communicating with you, there is no reason to ask to take a deep breath. In that circumstance, I would use ambu bag ventilation. If patient becomes hypoxic, withdraw the bronchoscope above the carina. Carina has got the largest amount of receptors leading to bronchospasm. When I pull my bronchoscope above the carina, SpO2 improves by 2 to 3 torrs. Reduce the amount or keep amount of Elocort used for BL as low as possible. We usually use 20 or less. Every bronchoscopy suite must have nasopharyngeal tube, the picture I showed you, and that could be placed to the opposite nostril if patient is not intubated and you are doing bronchoscopy through the nose. If patient still remains hypoxic, you can use non-rebreather mask. I'll show you certain masks where you can even do bronchoscopy on non-invasive ventilatory support as well. Supplemental oxygen can be provided to the flexible scope. If patient still remains hypoxic, use a smaller caliber flexible bronchoscope. If patient is still hypoxic, reverse the sedation, and then patient may even require intubation if patient is not already intubated. I will not go into details. You are more accustomed to use this thing than I am. So flumazenil is required to reverse midazolam, and morphine sulfate could be reversed with using naloxone. You know how to do it, so I will not dwell on it. Pre-procedure, every bronchoscopy suite must have a bite block. Let me show you what I mean by this. This is a blind bite block. No matter how paralyzed the patient is, if you ever want to put a bronchoscope through an endotracheal tube, you must use the bite block. As Atul Bhai says, patient is way out. What you call seizures, right? And if you have a bronchoscope through the mouth or the endotracheal tube, what patient is going to do is patient is going to bite the bronchoscope. This is $12,000 damage to your bronchoscope. Okay? So you should never put a bronchoscope through the mouth or the endotracheal tube which is going through the mouth without a bite block. No matter how paralyzed the patient is, that is as simple as that. Not only that, this would cause significant respiratory embarrassment if patient bites the bronchoscope and endotracheal tube. As soon as the bronchoscope touches the carina, patient is going to cough and is going to bite the instrument, okay? Now, these are the two masks one should consider having if you plan to do bronchoscopy in an ICU setting. This is a silicone endoscopy mask. As you see here, you can deliver 100% FiO2 through this mask and still insert your bronchoscope through this particular aperture. ICU setting, high flow oxygen, you can do this thing. This is better than a non-rebreather mask. You can almost deliver 100%. Even then, if patient is remaining hypoxic, Patel Syracuse mask, as you see here, this is a BiPAP mask. As you see these prongs, that's where you put the straps on. And then, through this particular aperture, you can introduce your bronchoscope to obtain specimen from endobronchial tree. And even after that, suppose patients remain hypoxic, one can consider doing bronchoscopy through the laryngeal mask airway, especially when I'm dealing with pediatric bronchoscopy, if I'm dealing with subglottic lesion, if I'm applying mitomycin to the vocal cords, mitomycin to the endobronchial lesion, as we did last time I was here, you can use the laryngeal mask. And if patient remains persistently hypoxemic, one can do bronchoscopy with this particular instrument. Okay, drugs and bronchoscopy. You can do bronchoscopy on a patient who is receiving aspirin. You should not do transbronchial biopsy if patient is receiving Plavix or clopidogrel. Okay? Ticlopidine or ticlip, it is okay to do bronchoscopy and transbronchial biopsy, but not the Plavix, not the clopidogrel. Clopidogrel is a very long-acting and very powerful antiplatelet drug, and its half-life is about 5 to 7 days. So I stopped Plavix for 5 days before I would ever do transbronchial biopsy in our patients. There is enough data to support what I'm saying. You know how to take care of warfarin-related INR increase, what medications to be used, IV heparin, you stop it for 2 to 6 hours, low molecular heparin, I would skip 1 dose or at least 12 hours free after the last dose. Sub-Q heparin, bronchoscopy and a lung biopsy is safe, and for other new agents, you follow the recommendations by the manufacturer. If patient is hemophiliac, I could still do bronchoscopy and even a transbronchial biopsy after infusing the patient with factor VIII, and that is just for your information. You should also know what are the risk factors of bleeding during bronchoscopy. Uremia, as you all know, literature says increased risk of bleeding 4 to 5%, 4 to 45%, average 6% chances of having massive bleeding after transbronchial biopsy in uremia patients. Thrombocytopenia, obviously, malignancy, other bleeding diastasis, and in immunocompromised patients, there is as high as 30% chance of bleeding following transbronchial biopsy. Pulmonary hypertension as such is not a contraindication to do transbronchial biopsy. Reasons, you can ask me a question, I may not have time to go into details. How do I treat thrombocytopenia before doing transbronchial biopsy? Stored platelets have half-life of less than 24 hours. So I transfuse 6 packs just before the bronchoscopy, and while patient is undergoing bronchoscopy, I give another 6 packs of the thrombocytes, and that's how I do transbronchial biopsy. I have done bronchoscopy and transbronchial biopsy in patients with got platelet counts as low as 10,000. Bottom line is risk to benefit ratio. Why are you doing bronchoscopy? If you want to avoid an open lung biopsy in a critically ill patient, yes, I would do bronchoscopy, but it is just for fun, I would not do it. So risk and benefit ratio. Renal failure and bronchoscopy. How do you do it? Okay, check the INR and platelet count. Bleeding time is not necessary. You do dialysis 24 hours prior to or within when you want to do flexible bronchoscopy and bronchoscopic lung biopsy. Correct the platelets the way I talked to you about. Correct the INR as you all know about. If patient has got renal failure, desmopressin or DEAVP has been used even though there are no randomized trial to reduce amount of bleeding after transbronchial biopsy. Conjugated estrogen in the doses as provided, it would also reduce the bleeding. Cryoprecipitate within 30 minutes of the procedure, and the chances of bleeding in renal failure patient is anywhere from 4 to 8%. 4% in patients who have renal failure, 8% patients who are on dialysis on a mean numbers. Now, patient is on ventilator. How do you do bronchoscopy? Aim is to safely obtain specimen and to avoid open lung biopsy. As I mentioned to you, hypoxemia, arrhythmias, pneumothorax rate is about 23%, as high as 23%. Bleeding about 14%. Myocardial infarction, these are some of the most severe complications of bronchoscopy in intensive care unit. Once again, measure the risk and benefit ratio. Sicker the patient, more need for open lung biopsy, especially when the time is of essence. You need diagnosis today, you don't have 48 hours to wait, you do the open lung biopsy. Once again, if you do bronchoscopy, goal is to maintain total saturation about 90%. Very important information for the critical care physicians or intensivists. If your bronchoscope is 5.7 millimeter in diameter, just very simple rule of thumb, endotracheal tube diameter has to be at least 2 millimeter wider than the outer diameter of the bronchoscope. I can take you to the entire literature of that, but just to remember that put 5.7 bronchoscope in an 8 or an 8.5 diameter endotracheal tube, otherwise you're going to make your patient more hypoxic and your bronchoscope is going to get stuck in the endotracheal tube. 100% FiO2, no more than 5 B, and if patient has got bronchospasm, treat the bronchospasm before you put the endotracheal, before you place the bronchoscope inside the endobronchial tree. A dedicated bronch assistant is a must. You must have a nurse or a respiratory therapist or a nurse's aide as your trained bronchoscopy assistant. Your chauffeur cannot be your bronchoscopy assistant. your chauffeur cannot leave your bronchoscopy system. Okay. These are the parameters I want to leave you with, that just to show you that if you have 9 mm endotracheal tube and your bronchoscope is 5.7 mm, it would take over 40% cross section of the diameter of the endotracheal tube. 7 mm, as you see here, 66% of the cross section will be taken up by the bronchoscope, and so on and so forth. If the